Welcome to Ask the Expert. This is a brief, informative, engaging, and lively discussion really about cutting edge science and advancements in type 1 diabetes research. We're going to have as our guest today, Dr. Anev Shalev. She's coming to us from UAB, or University of Alabama, Birmingham, and she received her MD in training at the University of Basel in Switzerland. After her postgraduate course in experimental biology and medicine at the University of Zurich, she came to the US and did a research fellowship at HM Harvard Medical School, and her fellowship training in endocrinology, diabetes, and metabolism at NIH in Bethesda. In 2002, she became assistant professor at University of Wisconsin-Madison and was later promoted to associate professor and director of endocrinology, diabetes, and metabolism research there. And then she moved to the University of Alabama at Birmingham as a professor of medicine in 2010, and went on to become the director of UAB Comprehensive Diabetes Center and the Nancy R. and Eugene C. Gwaltney Family Endowed Chair in Juvenile Diabetes Research. Dr. Shalev's research and her laboratory has pioneered the role of thyroredoxin interacting protein, otherwise known as TXNIP, in pancreatic islet biology, and continues to work on the translation of molecular findings into novel therapeutic approaches for diabetes. And her newest paper just came out in March 3rd, 2022, and is titled Exploratory Study Reveals Far-Reaching Systemic and Cellular Effects of Verapamil Treatment in Studies with Type 1 Diabetes, and that was in Nature Communications. So congratulations on that. Welcome, Dr. Shalev, and thank you so much for taking the time out of your busy schedule to talk to us about your work. I'm really interested to hear more about it.
Thank you. So what do you want to hear first? Just about the study roughly, or?
Sure. I mean, I think you have a few slides, right?
Coming from, yeah. So again, kind of to give you the background, we obviously were interested in finding targets that play an important role in beta cell death, and identified thyrodoxin interacting protein, or TXNIP, many years ago. We then were able to show in loss of function studies with knockout models that it really protects against diabetes in mouse models. And then we're trying to find pharmacological tools with which we could modulate TXNIP expression. And we're able to identify verapamil, which is otherwise known as a blood pressure medication. It's been out in the market for over 30 years, as a potent way of reducing TXNIP in islets of rodents, but also in human islets. And so with that, we were then able to show in vivo studies in mice that it was also protective and reversing diabetes. And so that allowed us to then go into the first human trial that we published back in 2018 in Nature Medicine, to show that new onset type 1 diabetes in subjects actually also responded to verapamil, and you were able to slow the progression of the disease. There was more remaining functional beta cell mass, and people that were on verapamil required less insulin as compared to those that were receiving placebo. And of note, this was not at any expense of having low blood pressure, and that was obviously a concern, being a blood pressure medication. So even young people, healthy people, tolerated verapamil very well. And so, but with that, we had shown that it was effective, but there were still a number of mechanistic questions that we didn't know. We didn't know exactly how it was working, how exactly was it affecting the human islets, and how long would the effect even last. The initial study that we published in 2018, patients were treated for 1 year, so we didn't know whether that beneficial effect would last any longer. And then how could we monitor it? As you know, the only way, that approved way in type 1 diabetes to monitor, is by mixed meal stimulated C-peptide on the curve, which is a bothersome test. And so to see whether we could find any better biomarkers. And that's where the current work comes in. So we followed out a subset of the subjects for 2 years, and actually were able to show that people that remained on verapamil did a lot better. So they had continued to maintain their beta cell function, and they required less insulin. Even that difference became even bigger after 2 years. However, those that discontinued the verapamil after 1 year, their levels and their beta cell function became very similar to those that had never been on verapamil in the placebo group. So it really required ongoing treatment, but it also serves as a proof that it actually was effective. And so that's kind of from a clinical standpoint, we were able to show that the beneficial effect lasts, at least in that small cohort, for at least 2 years. In addition, we did some mechanistic studies, and we looked at the effects of verapamil in human islets by transcriptomics, and found a number of pathways that were regulated, again, pointing towards TXNIP that we had expected, but consistent with that, also antioxidative, anti-apoptotic, but also immune modulatory gene expression profiles that had a beneficial change in response to verapamil. And then the most surprising finding was that we found that verapamil also had an effect on pro-inflammatory factors. And we did that by proteomics analysis of the serum of patients that had received verapamil and those that didn't. And that kind of showed for the first time that verapamil may have an effect actually on the autoimmunity of type 1 diabetes, in addition to its beta cell preserving effects. And it may explain why we see such a beneficial effect in the absence of a bona fide kind of immune modulatory regimen at the same time.
So it's kind of like a two hit. You're getting two.
Exactly.
Yeah, two benefits for one drug.
Exactly. So that was very, very surprising and very, very interesting to us. And then finally, as part of that, as I mentioned, the proteomics analysis, we discovered that chromogranin A, which has been used kind of as a marker for endocrine cells, was very strongly correlated with the effect, and it could be used beyond the acute phase. I mean, there's a number of tests that you can do for an acute onset type 1 diabetes that show kind of the decline of the beta cell function, et cetera. But to show kind of a therapeutic marker is something that we're lacking in the field and would be really helpful. And it looks like that chromogranin A may provide that, and it's a very simple test that can be done in any clinical lab, because it correlated very well with the beta cell function and with the effect of verapamil. So with that, we believe that we have a useful tool when we treat patients with preservative therapies for type 1 diabetes.
This is just, I mean, this is huge. I wonder if you can comment on, where verapamil and sort of the appreciation of chromogranin A, where in the prodrome window could this be best applied? I mean, stage 0, stage 1, I mean, can you extrapolate a little bit?
Well, the earlier probably the better. Here we obviously, those people had already been diagnosed. They were within 3 months of their diagnosis. So I think that's definitely, until then, it's useful. We believe that it may also work, that it's not so much the timing from when the diagnosis, but more how much beta cell function is still remaining.
Yeah.
So I think obviously the earlier the better. I think it would also be very attractive as a preventative intervention, especially since it's so well tolerated. But even in later stages, even in people that have had diabetes for several years, if there's still any remaining beta cell function, it may have an effect. And so I think that is still something that would have to be tested. But logically, based on the science, it should.
Yeah, it does sound like it's it can have benefits across the spectrum. Can you comment a little bit on how would this be a drug that's able to be prescribed for pediatrics, or is there a dosage issue? Is it indicated for pediatric use?
Right, so that's a very good question. So unfortunately in the US, oral verapamil is not approved for pediatric use officially, but it is being used under certain circumstances for cardiological indications. So it can be used in other countries. It is approved for children as well. So in terms of that, it would have to be used if anyone wanted off-label, obviously, and it would have to be tested for kids. There is no particular contraindication to be used in children. It's just the dosage would have to be adjusted accordingly.
And then you did touch on a little bit before before we started that, your study was a smaller study. It was successful and gave some great results, but that it's it being expanded in Europe. I didn't know if you wanted to kind of talk a little bit about that.
Sure. So actually, Nodia which is kind of part of TrialNet JDRF in Europe, is doing a multi-center, multi-country study trying to test verapamil in new onset type 1 diabetes. And so we'll obviously interested to see what the results are going to be.
What is the timeline for when the results will start being, made public from those studies? Do you have
That I don't know. Again, I think there have been delays, unfortunately, due to COVID.
Yeah. I wondered if, in terms of the other end of the spectrum, people have had type 1 for a long time period. We've seen cases of medalists who have still some beta functionality. I guess maybe I'm asking or thinking about whether or not those people might still benefit. And I know you said it's possible, depending on whether or not they have the beta cell function left. But, it seems like those people are older anyway. So maybe some of those, a subset, have already been on something like verapamil. I don't know. Is there any way to kind of mine those data?
Yeah, that's a great idea. It hasn't been done in the context of type 1 diabetes, but what's really interesting is that when we started working with verapamil, again, we initially were very surprised. And one question that we asked ourselves is, how come has that not been noticed? Because verapamil is a pretty common drug. There's a lot of diabetes out in the world. How come that connection or the association has not been noticed? And actually, when we started looking through the literature, there were some studies, actually only one, INVEST trial, that had looked at different blood pressure medication and the risk of type 2 diabetes. And they had actually seen that people taking verapamil had a lower risk, particularly Hispanic people had a lower risk of developing type 2 diabetes. So that was in the past. And after we published our study, there were other studies coming out looking at the biggest one is a very large trial that was done with Chinese record of their aging population, and particularly subjects over 65 who were on verapamil had a significantly lower risk of developing diabetes. So again, I think in the context of type 2 diabetes, it has been shown, those were 40,000 people a year. So very large studies that show the beneficial effect of verapamil. So I would think that it could also be true in type 1, longstanding type 1, as long as there's still some beta cell function left.
Interesting. In context of, this is sort of shifting gears for a little bit, but in context of the whole other realm of islet implantation, do you think there could potentially be a role for verapamil in that space?
Yes, absolutely. Again, I think it is something that protects the beta cell against cell death. And obviously we know that in islet transplants, one of the issues is that a lot of the cells are being lost in the very acute phase, but then also long term. So that could help with that aspect of the transplantation. Obviously, the large hurdle is still the immunosuppression, and that would have to be overcome in some way or other.
Yeah. It is kind of interesting, that your group did look at whether or not verapamil affected T cells, right? And you find the several pro-inflammatory markers of T follicular helper cells like CXCR5 and interleukin 21. Those were like really elevated significantly in the PBMCs in these people with type 1. And so you wonder if, like, as the immune system came online, this is totally speculative, but in an islet implantation event, if verapamil might be able to help kind of dampen that as well on that side. So, I mean, it's really curious to think about. And of course, experiments have to be conducted to investigate it, but it does seem like there's a lot of room for inquiry.
Yeah, absolutely. I mean, again, the immune aspect or the immune modulatory aspect of verapamil is completely novel, and we did not expect it, and it has not been described prior to that.
Yeah, no, it's fascinating. I wanted to see if anyone from the audience would like to ask a question.
Yeah, I would like to ask, what is the mechanism for the beta cell action?
For the beta cell?
Yeah, with the verapamil.
How it works on the beta cell? Well, so again, it targets, so verapamil lowers the expression of thyrodoxin interacting protein, or TXNIP, and TXNIP is quote unquote toxic to the beta cell. So what TXNIP does is it's a part of the redox system. It binds to thyrodoxin, and when it binds to thyrodoxin, thyrodoxin can no longer reduce oxidized proteins, so it increases the oxidative stress within the cell. And as you know, beta cells are particularly susceptible to oxidative stress, no matter from what type of stressor in the environment. And so by reducing TXNIP expression in the beta cell, those cells are then protected against exogenous stressors, whether they're due to the autoimmunity of type 1 diabetes or anything else. And so that's what we showed initially genetically, but then verapamil is able to mimic that.
Yeah, TXNIP's a mediator of ER stress in the beta cell as well, correct?
Correct.
So I wonder if anyone's done the experiment where they just had, human beta cells in the dish and kind of, stress them out with some CVB or roseola virus, and then tried to see if there was some kind of dose response of TXNIP that would calm that down. Has anybody looked at that?
I'm not aware of that. Not with viruses.
Like a stress test.
Yeah,
just see.
Yeah, but I mean, with other things, we've obviously looked with ER stress induction, like Tapsigargan, and with type 1 diabetes associated cytokines. So there's definitely the correlation there.
Interesting. Any other questions from the audience?
I have one question. Very interesting talk. I'm Ping Wang from Michigan State University. So my question is, I mean, besides this drug, I mean, have you tested other like calcium antagonist, I mean, in patient or animal model, like of type 1 diabetes?
Yeah, that's a very good question, because you're right. The effect of verapamil on TXNIP is not specific to verapamil. It's actually based on the lowering of calcium in the cell. And we showed that in the very early studies in vitro, that we can get very similar effects with the thiazum, which is another one, and even with a calcium chelator such as EGTA. We picked verapamil just because it had the strongest effect, particularly in human islets, and so that's why we went ahead with it. So we have not done any in vivo studies other than with verapamil. Having said that, I mean, what we also have, and that's a separate story. We don't have the time, obviously, to go into that at this point. But we also have worked on trying to identify a more specific tool to lower TXNIP and develop the small molecule that is inhibiting TXNIP expression, and that we published in Cell Metabolism, and we're now working on actually commercially developing that small molecule that has additional anti-diabetic effects, but also targets TXNIP.
Thank you. I really like the discussions between you and Dr. Monica, so the discussion of the type 2 diabetes and also the eyelid transplantations. So my second question is, like, is that possible this medicine also contribute to increase the blood supply to the eyelid? So, I mean, because it's hypertension medicine. So that's probably also could be benefit for the eyelid transplantation for the acute, loss of the hypoxia-induced eyelid grafts.
Yeah, it's a very good question. I have no idea. We would obviously have to look at that. I mean, again, it's not known that it's promoting kind of neovascularization, but what would be very consistent, I think, with its function is vasodilation. So if there are already vessels there, that it would allow more blood flow through those microvessels. So that would be conceivable, but I don't think that has been looked at, but it's a very good point.
Thank you.
That would then make it 3 for 1. 3
That's
benefits.
right.
So that would be, that's a really interesting point. Vishal, do you want to ask a question?
Sure. Thank you so much. And I can just imagine that, I'm sitting with Annette and Karsten, who I hold them in such a high regard and never thought I would be talking to them. So thank you so much for the opportunity here. My question was about the secretion of chromogranin A and whether, we know that insulin is released in a regulated manner. What do we know about chromogranin A secretion? Is it regulated? And how does that correlate with the beta cell mass and the function? So that was the first question. And the second question was about, when we apply Verapamil in the early onset type 1 diabetes. I was reading some of the reviews article and some of the work earlier. And there was this one article that I came across that shows that there's hardly 20% of the beta cell mass left in early onset type 1 diabetics. So is it possible based on this study, is it possible to conclude or correlate what is the residual beta cell function or mass is present in those early onset type 1 diabetics, which is sort of really hard, and type 1 diabetic community is struggling to answer that question. So thank you so much again.
Sure. No, those are 2 excellent questions. So in regard to the first one, so we were able to show that chromogranin A was very well correlated with the decline of functional beta cell mass. So the less beta cell mass, the more chromogranin A in the serum, and we believe it's just being released from the cells, and that's why we see it, and that's why we have that increase in type 1 diabetes, and that's been shown. Obviously, it's not specific; it has other. It's not only in the beta cells, other endocrine cells as well, but in the context of type 1 diabetes, that's why we think it's beneficial as a marker, and we see really the nice thing in our study, what we were able to show was that when people were taking the Verapamil, they maintained beta cell function and beta cell mass. Chromogranin A went down, and when they didn't in the placebo group, it went up. And those that stopped the Verapamil, you get that big increase in chromogranin A as soon as they stop taking the Verapamil. So you actually see that correlate very, very well. In terms of your other question with the fact that it's been out there that at the time of diabetes is only 20% left, I think that's debatable, and it's debatable for many reasons. We see a huge variability when we look, and again, this is currently the gold standard, when we looked at mixed meal stimulated C-peptide area under the curve as a measure of remaining beta cell function. When we looked in our patient population at 3 months, and this was very strictly at 3 months after diagnosis, so the given time point, the variability is huge. Someone may have still quite a bit, and others may have very little. So you can't really go by that. In addition, there's this whole new concept, and I think it holds very true, that not seeing, and that's I think also why we need better markers or additional markers, because what does the mixed meal stimulated C-peptide area on the curve tell you? It's also only how much C-peptide those beta cells can secrete in that given moment. And so if they're just stunned by the onset of the disease, they may not be able to secrete C-peptide, but they're still alive. They're there, they're just not producing. So the thought of cells that are just not functioning but still alive, or maybe even cells that have started to and differentiate, but with the right environment can be pushed back into full functioning beta cells that do their duty, is I think is a big one. And
Yeah.
so I think that is definitely the way we look at it, and the way we think that these therapies are working, and the reason why these therapies are working.
That's so interesting that you brought that up, because that brings up, Peter Thompson and Anil Bhushan's work, where they're talking about how some of these cells that are so stressed undergo senescence, right? Just sort of coming from the
Exactly.
cancer world, and then now they're offline. And then you're sort of saying like, well, if we can get the stress off of them, then maybe they can come back online. And it is kind of curious, right? Because it kind of plays well with this whole like clinical presentation. When a child or someone comes in DKA, they're given insulin, they're stabilized, and then they return to honeymoon. So the cells are not working, then they're in their honeymoon, they are working as a sort of that's sort of like a very mean situation, because then of course they descend back into diabetes. But that window of like being offline and then being online when they are released from their stress does kind of play well with the story of Tixnib and verapamil that you're talking about. So that's really, really interesting. I'd love to see some more work there. I wondered if you might just sort of, before we come to the end of our time, just tap on the whole idea of, there's a lot of talk about endotypes in type 1 right now. And like, it doesn't appear that this study suggested there was a differential, response to verapamil, right? It was, so
Yeah,
what does that
no,
say?
it's not. And we were, in a way, we were lucky with that, with the size of the study. We see very consistent, we don't have non-responders pretty much. So it really seems that this is universal. And it didn't seem to matter. The other thing was interesting. It didn't seem to matter. As I mentioned, there were big differences on where people started in terms of with their beta cell function, and that didn't seem to affect it either. So I think what we see now with the most recent study, what matters is that the treatment is continued. The moment it's discontinued, that's when we see the big difference.
Yeah, it's really interesting. And congratulations on the following this this work. I mean, I know you started, I think you sort of were diving into this in 2018, right? And as it's really come to fruition. So it's fantastic. And I can't wait to see what other, understandings and learnings are pulled from this kind of paradigm. So
Thank you very much.
thank you again for meeting with us, and wishing you all the best of luck.
Thank you. Thank you. Thanks for having me.